Hello everyone, I'm Dr. Priyanka Bansal. I'm an OBGY faculty at Medicoz Community and I welcome you warmly back for the second live session of 25 most important OBGY clinically based questions. A small reintroduction of Medicoz Community. As you all know, it's an e-platform for the PG aspirants which is offering various premium plans at high offers discounts, and you must avail this early bird offer right now as it is already live. So starting the questions, as I had already discussed 12 questions in the first session, I will straight away start with the 13th question now. If you have any doubts from the previous session, feel free to just send them on the Medicoz community group. Okay, so the 13th question is, which of the following is not an indicator for blood transfusion in pregnancy? So anemia is a favorite topic of every PG exam. So you should be thorough about all the indications and management of blood transfusion as well as the other iron therapies. So which is not an indicator of blood transfusion in pregnancy? Severe anemia at 36 weeks, moderate anemia at 24 to 30 weeks, blood loss anemia and refractory anemia. So first of all, we need to know the grading of anemia. That is, mild anemia is 10 to 10.9 grams, moderate anemia is 7 to 10 grams, severe is less than 7 grams, and very severe is less than 4 grams. So the choice of therapy in pregnancy will depend upon three important factors. First of all, what is the duration of pregnancy? It is early pregnancy, it is second trimester, it is full-term pregnancy. First of all, the period of gestation. And second important thing is severity of anemia. This is what I just shared. Is it mild? Is it moderate? Is it severe? And any associated complicated factor. For example, if there is antepartum hemorrhage, or there is not postpartum hemorrhage, but let's say the patient had suppose any accident, any trauma, so there is ongoing blood loss. So accordingly we will decide the treatment. And also one very important other factor is what kind of anemia it is. Okay, what kind of anemia? Now we know that the most common anemia in our country is iron deficiency anemia or nutritional deficiency anemia, that is also iron. So we will definitely be discussing the iron therapy in this question. Iron therapy, as we know, can be given as oral as well as parenteral. So during the antenatal care, as I told you, the period of gestation defines that at what treatment will be given. Now, suppose a patient is less than 30 weeks, okay? So iron deficiency is there. We have, confirmed that it is iron deficiency anemia with the help of CBC, with the help of peripheral blood picture. These two are mostly enough. In the CBC, the iron deficiency and the RBC profiles are sufficient enough to help in the diagnosis of iron deficiency anemia. So what treatment will you give? Oral iron. Because the patient is less than 30 weeks, oral iron is definitely the choice of treatment. However, if the patient is intolerant or non-compliant with the oral iron, then IV or IM, that is the parenteral iron therapy, can be also given. In case of folic acid deficiency, folic acid will be supplemented. Now suppose the patient is from 30 to 36 weeks, okay, and the patient is of iron deficiency anemia, we usually prefer parenteral iron therapy. The reason being that parenteral iron therapy will give an early increase of the rise of hemoglobin, because we know anemia per se is a risk factor for preterm delivery. And that is the reason we don't want to take the risk that now we are supplementing oral iron. Definitely the patient can land up in preterm labor. For that reason, to increase early the iron levels, we will give the parenteral iron therapy. That will be again by IM or IV route. Folic acid, however, can be compensated orally again. Now, if the patient is more than 36 weeks and the patient is anemia, of course, here we are talking about the moderate to severe anemia. Okay, moderate to severe anemia. Then, of course, we will have to give the patient blood transfusion. Okay, so this is a very important slide which will explain at what period of gestation what iron therapy has to be given to correct the anemia. So answer, if this you see the question, not an indicator for blood transfusion is severe anemia at 36 weeks. So of course I told you that if the patient is having moderate or mild anemia, only then iron therapy will be given. Otherwise, for severe anemia at 36 weeks, you will have to give blood transfusion. Of course, severe anemia means, as I've told you, less than 7 gram %. Moderate anemia at 24 to 30 weeks means moderate is, as I've told you, how much is the level? It is 7 to 10 grams or 9.9 grams, you can understand. Then moderate anemia at 24 to 30 weeks. Suppose any patient is coming, example 28 weeks, okay, and her hemoglobin is 8 gram percent. What will you give? Of course, it's a moderate anemia and she is less than 30 weeks. Oral iron therapy will be the choice of treatment, okay. Then blood loss anemia. Blood loss, as I told you, if a patient is having acute blood loss because of antepartum hemorrhage or any other cause, placenta previa, then obviously blood transfusion has to be given. Any refractory anemia. Refractory means that despite giving the treatment, the hemoglobin level is not rising. The disease is refractory. It is resistant to the treatment you are providing. In those situations, always blood transfusion is reserved. So that answers the question. Answer will be moderate anemia 24 to 30 weeks. In this, blood transfusion is not given. Next question. Now the assertion and reason question it is. Assertion, heparin is given in less than 12 weeks and after 36 weeks in pregnancy with heart disease. Okay. So less than 12 weeks you will give heparin and after 36 weeks in pregnancy with heart disease. So what do you think? Is this statement right? Okay. Yeah, it is a true statement. Reason? Because warfarin is a teratogenic in early pregnancy, but when given after 12 weeks, it has strong anticoagulant property. So what do you think? Is this statement right? Yeah, this statement is also right. And is it explaining also the assertion? Is it explaining the reason that heparin is given less than 12 weeks and more than 36 weeks? So yes, it is explaining because warfarin is not given in early pregnancy because warfarin is a teratogenic. As you can see, it will cross the placenta. Warfarin crosses the placenta and it will cause in the early pregnancy abortion chances, prematurity chances, any embryopathies. Particularly CNS and eye abnormalities, which can be seen in second and third trimester also sometimes. Also, why you have to stop it after 36 weeks? The reason for not giving in first trimester is because it is a teratogenic. But we are not giving after 36 weeks because it is an anticoagulant. Simple words, it's a blood thinner. Okay. So when, as we know that it is crossing the placenta, now, suppose the patient goes under labor, okay? At 36, 37 weeks, she goes under labor and warfarin is still being continued. This means that even the baby blood is having warfarin. This means the baby blood is very thin. This means that during delivery, the baby is susceptible to any kind of injury, especially the head trauma. The baby can have any injury, any clotting, any problem in the brain because of warfarin. That is the main reason it has to be stopped after 36 weeks and it has to be switched over to heparin because heparin will not cross the placenta and the anticoagulant property of heparin is not present in the baby, and that is why if the heart disease patient is having labor, the baby will be safe. So remember, this is a very important part. We have to switch over in heart disease patients. In the early trimester, we will give heparin. In the second and third trimester, majorly, we will give warfarin. And from 36 weeks, we will switch over back to heparin. The reasons I have explained right now. And also know what is warfarin embryopathy. Nasal hypoplasia, this means the nose does not develop properly. The bone epiphysis problem happens, the bones don't develop properly. The optic atrophy, eye problems will be there, blindness, seizures can be there. Overall risk is 5% and decreases with the use of unfractionated heparin in the first 3 months. That is why heparin is preferred over the warfarin. So answer will be option C, that both assertion and reason are true and the given reason gives an accurate explanation. Coming to the next question. This will be the last question of obstetrics. All are seen in gestational diabetes except previous macrosomic baby, obesity, malformation, and polyhydramnios. It's a slight tricky question if you see that all these options will seem to be right because in gestational diabetes you can have all these things. But here I want to explain a very important difference, and that is between the gestational diabetes and pre-existing diabetes. Please understand that gestational, whenever the word gestational comes, it means that the patient has developed diabetes during her pregnancy. She was normal before that. As soon as she became pregnant, her glucose levels started getting high because of the insulin resistance. Why this insulin resistance happens? In simple words, remember, there is one hormone HPL, human placental lactogen, which is secreted by the placenta, and this is something which is a very big enemy of insulin and it will cause insulin resistance in the body. Okay, so gestational diabetes actually will never cause an increased risk of congenital anomalies. Please understand that जब एक पेशेंट प्रेग्नेंट होती है और उसके बाद she becomes diabetic, this means gradually those sugar levels will become bad, gradually the sugar levels will become higher and higher. Those factors, जब तक ये होता है तब तक the initial part of a pregnancy has finished. Okay, that means the embryogenesis, that means the development of the baby has finished in the first trimester, and that is why in gestational diabetes congenital malformations नहीं होते हैं, they are not present, but they are present in mostly pre-existing diabetes. That's a very, minute difference. You have to always understand that pre-existing diabetic patients are at a higher risk of congenital malformations and miscarriages. Okay, so just means अगर किसी पेशेंट को पहले से ही डायबिटीज हो रही है और उसके बाद वो प्रेग्नेंट होती है, ऑफ कोर्स उसके बेबी को हाई रिस्क ऑफ कॉन्जेनिटल मैलफॉर्मेशंस होएगा. जो पेशेंट पहले नॉर्मल थी, प्रेगनेंसी के दौरान ड्यूरिंग हर प्रेगनेंसी शी हैज बिकम डायबिटिक, दिस मींस नाउ देयर विल नॉट बी एन इंक्रीज्ड रिस्क ऑफ कॉन्जेनिटल एनोमलीज. ओके, also know that gestational diabetes mostly are an increased risk of fetal macrosomia. The baby becomes healthy, बहुत big babies आते हैं. But in pre-existing diabetes, mostly, it's not always, but mostly IUGR will happen. Okay, so remember, if if you are getting a diabetic patient and uska baby in ultrasound is showing IUGR, this is highly suggestive that, and the patient is diabetic, this means that patient is pre-existing diabetic, not during it is not a case of gestational diabetes. Okay, and pre-existing diabetes में macrosomia भी हो सकता है. ओके, सो प्री एग्जिस्टिंग में दोनों चीजें हो सकती है, आईयूजीआर भी मैक्रोसोमिया भी, लेकिन जेस्टेशनल डायबिटीज में आईयूजीआर नहीं होता. Okay, and because of fetal macrosomia, the babies are at increased risk of sections. There's increased risk of metabolic syndrome and type 2 diabetes later in life. More than 50% of the gestational females have risk of developing frank diabetes in later life. And babies also born are at increased risk for obesity, glucose intolerance, and diabetes in adolescents. Pre-existing diabetes means they are very much at risk of high infections, vulvovaginal infections, and because we know diabetes is a very immunocompromised state, pregnancy is also an immunocompromised state, so it's like एक और एक 11 हो जाते हैं, and these patients are at a high risk of all kinds of infections. So recurrent UTIs will happen, vulvovaginal infections will happen, PPROM will happen. Remember these P's, okay? Preeclampsia, polyhydramnios, premature preterm rupture of membranes. Okay, so we know what is PROM and what is the difference between PPROM. Okay, let me just explain this also. When the patient is having rupture of amniotic bag or sac before she is in labor, but she is full term. Okay, she is not in labor but she is full term, that is known as PROM. Okay, premature rupture of membranes. But whenever she is before 37 weeks and then there is rupture of membranes, that is known as preterm premature rupture of membranes. So I hope this is difference is clear. Okay. These patients are also at risk of operative deliveries. Operative deliveries means high use of forceps and vacuum. Excuse me. Ketoacidosis in type 1, progression of microvascular complications. Caesarean section rates invariably increase due to fetal macrosomia, poor blood sugar control, polyhydramnios are associated with failure of induction. So more or less the pictures are somewhat overlapping, but then there are some accurate differences which you should be very clear about. Also note that the best test to assess the risk of fetal malformations is HbA1c. We know it is glycosylated hemoglobin, which shows the glucose control over the past 3 months. And that is why it's whenever a patient is coming and she's saying there is a history of family diabetes or a previous history of big baby or a previous history of diabetes, always do HbA1c. That will guide you whether she's a pre-existing diabetes or a gestational diabetes. We require the number to be less than 5.7 gram%. Please remember that. So it is to assess the risk of fetal malformation, and the best test to detect the fetal malformation is ultrasound. So I hope this difference is also clear. So moving on to the gynecology. In gynecology, I've tried to put more of clinical questions to make things more clear. So question 16. A 32-year-old female, please know in gynecology, age of the female is very, very important. Okay, a 32-year-old female presents to gynae clinic with infrequent periods. A hormone profile is done, and all of the following are consistent with polycystic ovarian syndrome, apart from increased androgen levels, normal FSH, normal estradiol, decreased LH, and low progesterone levels. Yeah. So, what do you think is the answer? Which of the following is not showing, it is not consistent with PCOS hormonal profile? Okay, so let me discuss a brief pathophysiology of the hormonal profile. The main problem in PCOS patient is what? The main problem is that they have a persistent high LH levels. Remember, the problem starts straight from the pituitary gland. There is a persistent high LH levels. Okay. Now, what will these LH levels do? These LH, we know it is a luteinizing hormone. Okay. Also, second problem is, this is the first problem. Second problem is there is genetic predisposition to excess ovarian androgen secretion. Okay. Now, what will happen? We know, briefly, if I'll just tell you that androgens, okay, androgens, they are converted to estrogens. By what hormone? Please know that it is aromatase, right? Aromatase, okay? And we also know that androgens, we know that there are two cells in the ovary, that is the granulosa cells and the theca cells, right? So the theca cells are the one which are secreting the theca cells are the one which are secreting the androgens, okay? And it is the granulosa cells which is secreting the estrogens. Please know this. This is a very important difference. I will just change the color to make you understand. Theca cells will secrete the androgens, and this androgen will go to another cell, that is granulosa cells, and there the androgens is converted to estrogen. Now what happens? This LH will keep on stimulating the theca cells. This LH will keep on stimulating the theca cell, and that is why there is theca cell hypertrophy. Please remember that. Okay, there is theca cell hypertrophy. So lot of theca cells are there, and lot of androgens are produced in this female. Of course, these increased androgen levels or increased testosterone levels is the reason that these patients have hirsutism or the unwanted hair, unwanted facial hair, chin hair, etc. Also know that this testosterone level will cause insulin resistant and hyperinsulinemia. Okay, there will be insulin resistance. That means a diabetic like state will be there in the body. Whenever there is increased insulin levels, those because the insulin is not able to work, okay, anywhere in the body, what will happen? This insulin will go to the liver, okay, and in the liver it will get bind, and it will decrease the sex hormone binding globulins. Okay, so what does this sex hormone binding globulin do? It is the protein which actually binds to the hormones. Okay, it is the protein which binds to the hormones. Now, since this level is decreased, so what do you think? The hormones are now free, or now they are bound? Of course, they are free. Okay, they are free to act, because जो protein उनको बांध के रखता है, that protein is deficient. So what will happen? The testosterone level will be more high. Okay, so if you can see, this is like a cycle going on. Okay, so testosterone levels will keep on increasing. It will cause more of insulin resistance, more of hyperinsulinemia, and more of decrease in the sex hormone binding globulin level. So this is the reason of high androgens. This is the reason of insulin resistance. Okay. Of course, the insulin resistance also is influenced by genetic and dietary factors, and that is the reason that always lifestyle modification is the first treatment for a PCOS patient. Okay. Also know that now these estrogen levels, they are increasing. Okay, because androgens to badi rahe, so as compared to a normal female, estrogen levels will be increasing, but then they are not at such a high level that they suppress the FSH to very nice levels. Okay, we know that estrogen jo hota hai, estrogen is actually doing what? It has to cause a negative feedback on FSH. We know this. Okay, but what happens? Estrogen level is increasing, but it is not increasing in a very surge way. Okay, it is persistently increasing, and that is the reason that FSH जो होता है, it is increasing, but not in a very high value. This you should remember, please. कि FSH का जितना requirement होता है, उससे कम के level में FSH रहता है. That is why LH तो बहुत ज्यादा है और FSH बहुत कम रहता है in these patients. And we know that FSH is follicle stimulating hormone. So when FSH level is not adequate, what will happen? The ovulation, जो proper ovarian cycle का जो follicular cycle study होता है वो नहीं होगा proper. So there is no development of a mature follicle because FSH level is low as compared to the normal and LH level is high as compared to the normal. So because of this altered FSH LH levels, the mature follicle is not formed. Lot of follicles keep on forming because FSH will keep on doing at least some work on the ovary, and that will lead to an ovulation. Okay, and that gives a typical picture as you can see over here in this ovary, right? As you can see, this is known as necklace pattern. Lot of small follicles will keep on accumulating. They will be forming a cyst, and that is why it is known as polycystic ovarian syndrome. Okay, so I hope I have not discussed till in there is a lot of theory behind it, but I have tried to summarize it so that in this question at least we can answer to the point. So now coming back to the question, which of the following will be the normal things? Increased androgen level is yes. Normal FSH, yes, we will consider normal to low, it will be there. Normal estradiol, normal to high, it will be there. Decreased LH. So this is something which is never happening in PCOS patient. I told you this is the main pathology. LH will be very, very high. And low progesterone levels. Yes, low progesterone levels will be there because what is the source of progesterone? It is a corpus luteum. And how does corpus luteus forms? By the rupture of a mature follicle. उसके बाद जो remnant होता है we call that as corpus luteum. अभी rupture ही नहीं हो रहा, anovulation हो रहा है, तो corpus luteum is not being formed, there is no progesterone. Okay, so the answer will be D. Okay, you don't have decreased LH, you have very high LH levels. Okay. So question number 17. A 28-year-old female attends a colposcopy clinic after an abnormal smear test. The smear, of course, we are talking about the pap smear, okay? The smear is reported as severe dyskaryosis and she has an intrauterine copper device in situ. All of the following statements are likely to be true apart from. So basically they're asking which is a false statement, right? So first of all, we know pap smear is what? It is a screening test for cervical cancer. If any problem do we find in pap smear, what is the second step? It will be colposcopy. Okay. Now, whenever you do the colposcopy and the cervix can appear macroscopically normal. Yes, this can be true. What we do in colposcopy is we apply certain chemicals. Now these chemicals, what they will do, जो भी cervix का खराब part होता है, okay, the damaged part, the pre-malignant part, the cancer part, that those cells will be different than the normal cells. So these chemicals like acetic acid we apply and the Lugol's iodine we apply. Remember, these cells are very active, okay? They have high number of proteins because they are dividing at a very fast rate. That is why, because of these chemicals, they will react in a different manner than what a normal cell will react, okay? Understand that. So whenever you apply a simple chemical like acetic acid, those bad areas will become white areas, okay? So that is why it is known as acid to white areas, acid to whites, okay? A normal area will remain pink, but a bad area, a bad cervix area will become white. Acetic acid is applied and an irregular white area is apparent to the left of the cervical os. Now Lugol's iodine is applied and the same area stains dark brown. Now this is, you should understand that the bad area is something which will become pale and the good area will remain dark brown. I will just explain all this with the help of images. A biopsy can be taken with the help of colposcopy. The IUCD can stay as it will not aggravate the cervical abnormality. So remember, this statement is absolutely right that cervical smear, if you take or you do colposcopy or whatever you do, but IUCD, if it is there, it has nothing to do with the cervical cancer or pre-malignant lesions. Now this is a chart which is explaining that if when you do a pap smear and these are the findings, what you usually do. In simple words, if I put all this thing, remember pap smear, I just want to highlight this thing very nicely. Pap smear is only a screening test. You'd never treat on the basis of pap smear, okay? Because it's just a screening test. Whenever any abnormality is there in the pap smear, okay, dyskaryosis, LSIL, ascus, whatever you get, second step always is colposcopy. Please remember that, okay? This is something you should always remember. And then based on the colposcopy results, you will start the treatment. Just based on pap smear, you will never start any treatment for the patient, okay? So whenever you do pap smear, these are the various things as I told you. Mostly you will follow up with a colposcopy as you can see. Nowadays even HPV DNA can be done. HPV DNA is again done in the same manner as pap smear is done. Okay. So this is I was emphasizing on. See, this is a normal colposcopy. So colpo means remember cervix. Okay. So with the help of a camera, we are visualizing the cervix in a magnified manner. This is known as colposcopic findings. So if you see, this is the external os. I'll just change the color. This is the external os. Okay. So this is a full cervix you can see, right? If you see inside, okay, now cervix, if I see from inside, okay, this will have columnar cells, okay, and when it grows externally, this area will have squamous cells. So in the canal, it will be columnar cells. Outside, there will be squamous cells. But then there's a transition, okay, there's a transition from columnar to the squamous cells, and this is known as the transition zone, okay, transformation zone or transition zone. Remember, transformation zone, okay. So if you see, this is this area has been highlighted with a with mature squamous metaplasia. Okay, the metaplasia is a normal physiology. It is completely normal. As you can see, this will be the original SCJ means squamo columnar junction. Squamous cells का और columnar cells का junction है. ये original था और ये new है. Okay, so this is the new one and this is the old one. So this is the whole thing. जहां ट्रांजिशन हो रहा है फ्रॉम द कॉलमनर सेल्स टू द squamous cells, remember, and this is known as squamous metaplasia. Okay, this is a normal physiology which is happening. Remember, this is the zone where the cervical cancer will happen. Okay, because here is the cells where a lot of activities of the cells is happening, and that is why the HPV virus will go and infect in this region of the cells and can cause cervical cancer mostly. Okay, mostly. Yeah, so this I was telling about the acetic acid, you can see. Okay, so acetic acid 3 to 5% it will be there, and you can see now this is without acetic acid. Now you can see this area, it's so clearly demarcated. Okay, this is known as aceto white area, aceto white, and this is a pale area. This means अगर अब आपको next step क्या करना होगा, you will take the biopsy from this area only, so that जो भी खराब टिश्यू है, जो भी खराब सर्विक्स का टिश्यू है, वो यहीं से आपको लेना है. यहीं से आपको मालूम पड़ेगा कि भैया प्री मेलिग्नेंट है या मेलिग्नेंट नेचर है, whatever is the nature of the disease you will find from here. But this you should understand कि aceto white area से आपको लेना है. Similarly, if you see Lugol's iodine, this is the second part I was asking. This is without the application of Lugol's iodine. अभी Lugol's iodine apply कर दिया. So now you see that columnar epithelium has not taken up the iodine, and squamous epithelium has taken. This means the normal cervix will be dark. The normal cervix will be dark and the abnormal will be pale. Okay, so this is the answer. If you see that Lugol iodine is applied and the same area, that is the irregular white area, will stain dark. No, it will not stain dark. It will also be pale. It will be pale. Okay, and the rest of the cervix will be dark. So I hope this is clear. Okay, and Lugol's iodine stains abnormal dark and rest of cervix pale. No, that is not a abnormal will be pale and the normal of the cervix will be dark. Remember, that is the way Lugol's iodine will stain. Coming to the next question, a 24-year-old female presents with absence of periods for 9 months. She started her periods at the age of 13 years. Regular periods से 28 days के cycle थे until 1.5 years ago. The periods then became irregular, occurring every 2 to 3 months until they stopped completely. Okay? Irregular हुए, delayed हुए, and फिर बंद हो गए. The following are all included in differential diagnosis of secondary amenorrhea apart from what? Excessive exercise, hyperprolactinemia, hyperthyroidism, premature ovarian failure, and significant weight loss. Okay, so basically this is a question of amenorrhea, right? Yeah. So now we will discuss about amenorrhea. Causes of secondary amenorrhea. Please remember, even for unmarried females, always rule out pregnancy. Okay, always, because that's the most common in fact. Thyroid disease, hyperprolactinemia. This is a list you will have to kind of mug up, but still there are some points which you can understand also. Okay, now remember these 3 points. Okay, so normogonadotrophic amenorrhea, hypergonadotrophic hypogonadism, hypogonadotrophic hypogonadism. Now what does it mean? See, whenever we are talking about gonadotrophic, this gonadotrophic means actually hypothalamus and pituitary. Okay, Please remember this. Because we know that for a normal menses to occur, there has to be an intact HPO. Okay. Hypothalamus, pituitary, ovarian axis. Hypothalamus, pituitary, ovarian axis. This HP part is known as gonadotrophic, and this ovary part is known as gonadism. Okay, these are the gonads because these are the gonads, isn't it? So hypergonadotrophic means hypergonadotrophic, hypogonadism means the ovaries are not working properly. That is why to compensate for the ovary function, there is an excessive function of the HP. Okay, that is known as hypergonadotrophic. Now, what is hypogonadism? Hypogonadotrophic. Hypogonadotrophic means the HP is not working properly. There is a central problem itself. So, of course, the stimulation for the ovary will not be there, and that is why ovaries will also be hypogonadism. Okay, so this is a very important difference you must understand, that hypergonadotrophic hypogonadism and hypogonadotrophic hypogonadism. Then there is something called as normogonadotrophic amenorrhea. Okay, that means outflow tract obstruction will be there, or hyperandrogenic anovulation. Hyperandrogenic anovulation, just now we discussed. Typical example is PCOS. Remember, causes of secondary amenorrhea can be hyperprolactinemia. Normal prolactin level is less than 25. Okay, less than 25. If it is like more than 25 but less than 100, and more than 100 means these are the different reasons. Of course, whenever it is more than 100, you have to rule out for any tumor. Okay, other for less than 100, it can be medications, breastfeeding, substance abuse, any medicines, any ectopic production, etc. But hyperprolactinemia can be a cause of secondary amenorrhea. Menopausal ovarian failure, of course, this is known as premature ovarian failure, POI, we call it now, premature ovarian insufficiency. Okay, now this can be because of various reasons: autoimmune, chemotherapy, idiopathic, mumps, pelvic radiation, genetics. Okay, so the whole thing is that menopause बहुत जल्दी हो गया उस female को, and that is why she is not having a periods now. Okay, now secondary amenorrhea, hypogonadotrophic. So hypogonadotrophic means HP में problem है, hypothalamic और pituitary में problem है. So these are the various reasons. एनोरेक्सिया, बुलिमिया नर्वोसा, एक्सरसाइज ज्यादा हो रही है, वेट लॉस बहुत हो रहा है, बहुत ज्यादा स्ट्रेस हो रहा है. ड्यूरिंग कोविड लॉट ऑफ पेशेंट्स हैड दिस एमेनोरिया. दैट वाज द रीजन, बिकॉज excessive stress can cause all this. Sheehan syndrome, chronic illness, CNS tumor, cranial irradiations. Yeah, then you have hyperandrogenic anovulation. Typical example, I've just now discussed polycystic ovarian syndrome, but then there can be other also endocrinopathies which are causing increased of androgens, like androgen secreting tumor, congenital adrenal hyperplasia, acromegaly, Cushing's disease, exogenous androgens. Then you are coming for the outflow tract obstruction. So this means normogonadotrophic is going to be there, isn't it? Asherman syndrome and cervical stenosis. This is a vast list. You will have to, kind of learn only. But as I told you, there can be a logic which can be related to it. Now, if you see, what will be the answer in this question? That the patient is actually 24 years, and gradually she had a delayed periods for approximately 1.5 years, and after that she's not having any periods. So what can be the differential diagnosis except? So excessive exercise, hyperprolactinemia, hyperthyroidism, premature ovarian failure, and significant weight loss. So I think all of this will be, can be definitely there. But usually hyperthyroidism, hyperthyroidism is something which will, see, thyroid disorders can alter the periods anyways. Previously, it was thought that hypothyroidism usually causes heavy periods and hyperthyroidism causes less periods. But now this theory is no longer supported, and that is why, the best answer if we have to choose is hyperthyroidism, because others are definitely proven to cause amenorrhea. Okay. So answer will be hyperthyroidism. I think, I've got the wrong answer there. Okay. So coming to the next question. The following statements regarding adenomyosis are true apart from this one. So it tends to occur in women over 35 years. Risk factors include increased parity, termination, and quick labors. The condition commonly occurs in association with endometriosis. With each period, bleeding occurs from the endometrial tissue into the smooth muscle. The diagnosis can be made by ultrasound or MRI scanning. Now, first of all, what is adenomyosis? Okay. Remember, if a patient is coming in her 30s, 40s with a complaint of dysmenorrhea. Dysmenorrhea is what? Painful periods. Severe painful periods. She's having severe pain during intercourse. Okay. Dyspareunia she's having. She's having pain during urination. She's having pain during motions. Severe pain. Main complaint is pain. Always remember, two differential diagnoses are going to be there. Okay. Whenever in history also they are emphasizing more, on the pain, then it is going to be either endometriosis, adenomyosis, or both of them. Both of them can also coexist because kind of the theory is similar. The theory is somewhat that the endometrium of the uterus has spread to other areas. When it has spread outside the uterine cavity, it was known as endometriosis. And when the endometrium has infiltrated the myometrium, okay, of the uterus, that is known as adenomyosis, okay. So kind of theory is similar. Now, if you see, this is a cut section of the uterus, right? The endometrium is this much. Hemorrhagic and necrosis areas. Hemorrhagic and necrosis areas in the uterus is known as adenomyosis. Okay. If you see the areas of adenomyosis, this is a typical image of adenomyosis. I'll just change the color to emphasize. Yeah. You can see this. Okay. This is known as myometrial cysts. Okay, and if you can see, this is a whole this is a, first of all, what is this? It's a TVS. Okay, let me just tell you. It's a transvaginal sonography, which is showing that this is a full uterus. Okay, this is a uterus. The uterus becomes bulky, globular. Okay, bulky, globular, and mostly adenomyosis is in the posterior wall. Okay, posterior wall. And there can be myometrial cyst, and you can see this as compared to the other area. This is a whitish area, this is a blackish area. Okay, a generalized diffuse mass will be there, and the patient is complaining of all these dysmenorrheas. Dis will be there, painful things will be there. This means the diagnosis will go for adenomyosis. Okay. Yeah. So as I told you, this will be in after 30s. Risk factors: increasing parity, early menarche, short menstrual cycles. More of see, the whole idea is that endometrium is basically infiltrated. Okay, endometrium has infiltrated into the myoma. Okay, so जितना ज्यादा उस पेशेंट को पीरियड्स होएगा उतना ज्यादा यहाँ से भी ब्लीडिंग होएगा. जितनी शॉर्ट साइकिल्स होएंगी, जितना अर्ली प्रोलॉन्ग पीरियड होएगा, अर्ली मिलार्की, लेट मेनोपॉज, any history of previous C-sections, endometrial curettage, evacuation, all these things are the risk factors for adenomyosis. Sometimes because of antidepressant drugs, because they cause hyperprolactinemia, or tamoxifen because of estrogen agonist action on the endometrium. So जो भी factors estrogen को support करते हैं, because estrogen is the one which is a kind of patients को menses ज़्यादा हुई. Okay, that is the reason this patient will have more of chance of endometriosis as well as adenomyosis. So remember, it tends to occur in women above 35, right? Risk factors include increased parity, termination, and quick labors. Now, increased parity to sahi hai, lekin termination and quick labors is not the right thing for adenomyosis. The condition commonly occurs with endometriosis, again, right? With each period, bleeding occurs from the endometrial tissue into the smooth muscle. Yeah, basically, this is the definition of adenomyosis, or yahi hota hai. And the diagnosis can be made by ultrasound or MRI. That's also true. So the answer will be B. Okay. The risk factors are not termination and quick labors. Coming to the next question. A 35-year-old female requires long-term reversible contraception. You advise that the method that can provide the longest protection is what? So there is, I don't think, any PG exam without any contraception question. So contraception should be on the tip of your fingers. Okay. So the longest protection by contraceptive implant, copper T, Depo-Provera injection, IUS, that is intrauterine hormonal, and laparoscopic sterilization. So first of all, she's asking for reversible. Okay, reversible contraception means ये तो वैसे भी out of question हो गया. Sterilization for now is considered as a permanent method. It's not reversible. Abhi will see in this image, you can see this is copper T, or it is known as Paragard also. It has a life of 5 to 10 years. Hormonal IUD or Mirena has a life of 5 years. Implant or Implanon has a life of 3 years. You have to learn all that. Vaginal rings are also available, but their life is only 1 month now. Okay, this is known as LARC. Long acting but reversible contraceptive. So of course, which is the one having the longest life is of course the copper T. Okay, so answer is very clear. Copper intrauterine device. Okay, Depo-Provera injections, please know that they work for 3 months. 3 months. Okay. We have seen intrauterine hormonal system is Mirena, that is for 5 years. Okay, contraceptive implant, implant is this only 3 years. It will be also 3 years. So copper T can work for 5 to 10 years. Okay. So you will advise a copper T. Yeah, okay. So the next question. Question 21. Okay. So regarding cervical cancer, which is true statement? HPV, I'm not able to remove this. 1 minute. Not able to remove this. Okay. Anyways, please ignore this. 3 years and 5 to 10 years, it's come on the screen. Okay. I just changed the color. Regarding cervical cancer, which is true statement. HPV type 6 and 12 are high risk for developing cervical cancer. New vaccines can prevent invasive carcinoma but not sin. As soon as a new vaccination is introduced, cervical screening programs can cease. HPV type 16 and 18 account for majority of cervical cancer in the UK, and HPV is oncogenic virus for squamous cell but not adenocarcinoma of the cervix. Now in this, which of the following is true? Let's see each statement, okay? Just give me a minute, please. I'm not able to erase these. Graphene follicle develops during the luteal phase. Now this is wrong. We know that it develops during the follicular phase. Okay. Yeah, and I'll correct myself. This is a vasoconstriction. Okay, I'm sorry. This is a vasoconstriction. Okay, and the LH surge triggers not menstruation but the ovulation. Okay. The LH surge triggers the ovulation and menstruation is happening because of the constriction of the spinal arterioles. Both the follicle and corpus luteum secrete estradiol. This statement is right because follicle, as I have told you, is secreting estrogen and corpus luteum is secreting estrogen as well as progesterone. But this statement is right. And progesterone level falls after the onset of menstruation. Now, if you see that menses have happened, the progesterone level will fall. Of course, it will fall, but not after the menstruation. It is before the menstruation itself it will fall, and in fact it is a progesterone level falling which will cause the onset of menstruation. Okay, so it is very important to understand that when the progesterone level falls, then the menses will happen. That is known as a withdrawal bleeding. Okay, so I hope this answers the question now, that both follicle and the CL will secrete the estradiol. The other options are wrong. Coming to question 23, which is not true pertaining to this image. If you can see, blocked tubes can be identified. First of all, what is this image? We know it is a HSG or hysterosalpingogram. Why it is done? Because of knowing the patency of the fallopian tube for an infertile couple. When it is done after the periods are over. Okay, that is in the follicular phase, but after the periods. Okay, and what is the other advantage? Uterine anomalies can be identified. How do you do that? It is an X-ray in which a Leach-Wilkinson cannula, okay, it's a Leach-Wilkinson cannula which is inserted and an opaque dye is pushed through that cannula, and that cannula will fill the uterine cavity and will flow out through the fallopian tubes. If the fallopian tubes are patent, you will see the spillage of the dye. You will see the spillage of the dye in the peritoneal cavity or the pelvic cavity. Okay, this much you should know. So block tubes can be identified. That is the main reason you are doing that. Uterine anomalies can be identified. That is an added advantage. The cannula uses Leachman-Wilkinson. So this is an image of the Leachman-Wilkinson. Okay. So basically all the options are right. Okay. And none of the options is false. Remember, it is HSG, and other tests for doing the tubal patency test are SSG, and the gold standard will be laparoscopy. Okay. Remember that. So hysterosalpingography, I've already told that for tubal patency is done. It's a first-line diagnostic test for assessing tubal patency as well as the outline of the uterine cavity. It has been suggested that somewhat it has a therapeutic role in enhancing subfertility. But remember, it has a sensitivity of 95.6% and specificity of 60% only. Coming to question 24. A mother brings a 19-year-old daughter to your clinic with complaint that she has not started her menses yet. General examination shows normal developed breast and pubic hair. On pelvic examination, vaginal ending is blind and the uterus is not palpable. What do you suspect? Mullerian agenesis, Asherman syndrome, gonadal dysgenesis, or Turner syndrome. Okay. So primary amenorrhea case. This is very important to understand that always whenever a primary amenorrhea case is coming, a history and physical examination is very important. Okay, you have to take a detailed history of when whether the pubic hair have developed and whether the breast have developed, whether the underarm hairs have developed. Remember, the breast developed because of which hormone? It is always the hormone estrogen. Okay, and the pubic hair and the underarm hair, they develop because of the androgens. Even in a female, breast development will happen because of estrogen. Breast development in males will happen because of estrogen. Pubic hair and underarm hair, both sexes, will happen because of which hormone? Because of the androgens. Okay, so when a female is coming to you and you say that normal developed breasts are there, this means what? Ovaries are present. Ovaries are present. Why? Because ovaries are the source of estrogen. Breasts are present means estrogen is present. Estrogen is present means ovaries are functioning. Okay, and pubic hair is also present. On pelvic examination, vaginal ending is blind and uterus is not palpable. So what is the next diagnosis? What is the next investigation you would like to do? Of course, the first investigation in this case will be an ultrasound, because in ultrasound you will see whether the uterus and the ovaries are present or not. However, ovaries to hai hi, because I told you breasts are present, but uterus is present or not, which we have to see. Remember, embryological development of ovary and uterus is different. Okay, it is not same. They develop separately, which we'll also learn gradually. Okay. Yeah. Okay. So history and physical examination relevant to the causes of amenorrhea with secondary sexual characteristics. So of course you will do a UPT, because even a primary amenorrhea, sometimes pregnancy has been seen as a cause of primary amenorrhea. Basic hormonal profile, pelvic ultrasound, including both kidneys. Now whether uterus is present or uterus is not present. Okay. If uterus is present, okay, then this means what? Uterus is present and ovaries, whether ovaries are present or not. This, how will we assess whether the ovaries are functioning or not? Reduced LH and reduced FSH. Okay, so just now I told you that whenever it is a reduced from the LH FSH, this means pituitary is not working. It will be a hypogonadotrophic. Okay, so treatment you can do is what? You will give the hypogonadotrophic treatment, that is, you will supplement the patient with FSH and LH. Suppose now the patient is having normal LH and FSH and there is uterus also present. When there is normal FSH LH means there is ovary also which is functioning properly. Uterus is also functioning properly. Then why she is not getting the periods? Because of outflow tract obstruction. Okay, outflow tract is stopped. So basically the treatment will be surgery. You just remove whatever is obstructing the part and then the patient will get a normal cycles. Increased LH-FSH. This means why? Because as I told you right now, that it's a estrogen which causes a negative feedback on FSH and LH. And if pituitary is secreting more of LH-FSH means ovary is not giving its negative feedback. This means ovary is not working properly. That is why it is known as primary ovarian insufficiency. And that is why you will have to do a karyotyping to confirm whether the embryological development of ovary has been proper or not. Okay, if it is Turner syndrome, we know it is 45XO and there is gonadal dysgenesis. Ovaries are not formed. It is known as streak ovaries. Or they can be sometimes Swyer syndrome also, that is 46XY, which is basically a testes has been developed. Okay, so remember, if increased FSH LH level, you will do the karyotyping. Now uterus itself is not there. Then also you will do a karyotyping with the testosterone. If uterus is not developed and the karyotyping is showing 46XX, it will be Mullerian agenesis. And if androgen insensitivity is present, that will be showing 46XY along with absence of uterus. Okay. So now if you see this question, she is 19-year-old, primary amenorrhea, breasts are there, pubic hair is there is no uterus. Okay. What do you suspect? Mullerian agenesis. This can be a possibility, isn't it? Because uterus is not there, ovaries would have developed properly. Ovaries ने estrogen निकाला होगा, breast develop हो गए, ovaries ने androgens निकाला होगा, pubic hair develop हो गया. Asherman syndrome usually has a very typical history of DNC in past or abortions in past. gonadal dysgenesis. See, gonadal dysgenesis cannot be the reason. Why? Because अगर gonads नहीं होंगे तो फिर estrogen या androgens कहाँ से आ रहा है, कहाँ से breast develop हो गए? That is why gonadal dysgenesis will not be the answer. Turner syndrome is again a synonym of gonadal dysgenesis. The answer will be, in this case, will be Mullerian agenesis. Okay. So I hope this is clear. Okay. Now coming to this question. Last question actually. A 30-year-old female multipara has uterine prolapse. The management of choice will be what? So it's a discussion on prolapse in this question. Okay. So first of all, prolapse. When to treat? Remember, हर किसी को नहीं treat करना है. जिसको प्रॉब्लम हो रहा है प्रोलैप्स की वजह से, जिसकी क्वालिटी ऑफ लाइफ इफेक्ट हो रही है प्रोलैप्स की वजह से, केवल उसी को ट्रीटमेंट आप दोगे. We see lot of patients who have cystocele, but they don't have any problem. तो हम उनको ट्रीटमेंट नहीं करेंगे. We don't give any surgery or any kind of treatment to those patients. जो हमारे पास खुद से आ रहे हैं उस प्रॉब्लम को लेके, हमें उन्हें ही ट्रीट करना है. ओके. तो मैनेजमेंट इज वेरी इंपॉर्टेंट. चॉइस ऑफ मेथड विल बी डिपेंडिंग ऑन द एज, fitness and wish of the patient. Age, fitness and wish of the patient and the parity and wish for further pregnancy. ये बहुत इंपॉर्टेंट है एक प्रोलैप्स के केस को लेकर. रिमेंबर, जो बाकी सारे कोमॉर्बिडिटीज होते हैं जैसे कि यूटीआई हो गया या द कॉज ऑफ प्रोलैप्स लाइक स्मोकिंग, ओबेसिटी एक्सेट्रा, दिस आल्सो हैज टू बी treated before you go for the actual treatment. Pessaries. Now, what is the indication of pessaries? Remember, the main indications will be age, बहुत ज्यादा एज है, पेशेंट इज नॉट फिट फॉर सर्जरी, पेशेंट इज रिफ्यूजिंग सर्जरी, या प्रेगनेंसी. ओके, इन प्रेगनेंसी इफ देयर इज प्रोलैप्स, you will give pessaries, and pessaries we know can be support or space filling. Okay, so these are the various type of pessaries which are inserted through the vagina, and they are specially for those patients who don't want the surgery. Abhi, vaginal hysterectomy with pelvic floor repair, it is known as ward myo repair. Okay, it is in fact the commonest operation performed in cases of uterovaginal prolapse, in cases where childbearing is complete, family is complete. Then you will move on for vaginal hysterectomy with a pelvic floor repair. It is usually combined with a repair of cystocele, enterocele and rectocele. Cystocele मतलब bladder का भी prolapse हो रहा है. Enterocele मतलब bowels का prolapse हो रहा है in the pouch of Douglas. And rectocele का भी prolapse हो रहा है. Sacrospinous colpopexy. Remember, in cases of procedentia with complete vaginal eversion and in cases of wall prolapse. What is procedentia? The whole uterus is out. The whole uterus is out along with the ligaments and the full vagina is out. So in those cases, you will do the hysterectomy because the ligaments are so weak that जब आपने surgery complete कर दी होगी, जब vagina को आपने suture कर दिया होगा, that vagina is known as the vault. The vault is so weak that again there is a chance of vault prolapse only. So उस टाइम उस vagina को support करने को आप sacrospinous ligament जो होता है, that is the sacrum bone से लेकर ischial spine, sacrospinous ligament जो होता है, उससे आप vagina को mesh के through attach कर दोगे. Okay, you attach the vault with the sacrospinous ligament and you give support to the vault because that sacrospinous ligament is a strong ligament. तो उससे vault जो है ना वो लटका रहेगा and it will not prolapse. Okay, so vault of vagina is attached to the sacrospinous ligament and it is done through the retrovaginal space axis. So this is a sacrospinous ligament which I am telling you. Okay, and this is like the vagina has been, उसे हमने लगा दिया. We have ligated with the help of mesh or by sutures the vagina. Leaford repair or colpoclesis. Leaford repair is reserved only for very elderly patients, जो कि who are not fit for surgery at all. And in those cases, we will just obliterate the full vagina. पूरा vagina बस suture कर देते हैं. We just close it. It's like this. Okay. Leaford procedure. Manchester for the girls, it's actually not much useful. It's required for those females who have completed their families but wish to retain the uterus. Or in other words, they wish to have the menstrual cycle still going on. Suppose you get a female of 30 years. She already has 3 children. But she does not want hysterectomy because she's very young. She wants, I still have to continue my menses. And she has prolapse. So Manchester or Fothergill operation is a good option for her. Okay. It is best for young females who have completed their families. Young females होने चाहिए. So Manchester repair का, in simple terms, you just cut the cervix. क्योंकि cervix जो आ रहा है, जो नीचे prolapse हो रहा है, you cut the cervix, you shorten the cervix. Okay, it is known as amputation of the cervix. And vagina से जो कटा हुआ बाकी का cervix है, vagina से हम उसको cover कर देते हैं. This is known as Fothergill's operation. Okay, and use of mesh, it is now very much used in repeat surgery. Purpose is to completely replace the patient's own weak tissues. It can be used while performing an anterior or posterior colporrhaphy. Colporrhaphy means repair of the pelvic floor. Pelvic floor means levator ani, okay, and the endopelvic fascia. Endopelvic fascia is actually the main reason. Weakening of the endopelvic fascia is the main reason for weakening of the support of the vagina giving to the bladder as well as to the rectum. And that is the reason cystocele and rectocele are happening. And we actually suture the endopelvic fascia and give the support to the bladder and the rectum. But with mesh, the main problem is of mesh erosion. Okay. Enterocele, as I told you, it is in the pouch of Douglas, and the vaginal surgery is like basically you just close the peritoneum. You close the peritoneum so that जो bowels pouch of Douglas में prolapse हो रहा था वो नहीं होगा. If you close this through the vaginal surgery, it is known as Meckel cultoplasty. If you do through the abdomen approach, it is known as Halban procedure or Moskowitz procedure. And so, just the answer for this question will be 30-year-old female है, multipara है, uterine prolapse है. The management of choice is what? Young female finished her family. What will be the answer? Fothergill repair with tubal ligation, sling operation या vaginal hysterectomy. Sling operation, remember, it is reserved for nulliparous females, okay, not for multiparous. Because fothergills में basically you're cutting the cervix, तो आगे चल के if she becomes pregnant, there's a chance of cervical incompetency. That is why you don't advise pregnancy after fothergill operation. Okay, sling operation is for nulliparous females. Multipara के लिए you will do fothergills. And of course, if she is looking for family planning, which you assume क्योंकि multipara है, तो fothergill repair with tubal ligation will be the best answer in this. Okay, so with this I have finished the prolapse discussion as well. So thank you so much for this class. I hope you have enjoyed. I'm really sorry once again for some technical errors which were happening during the class. But I hope this is a video. You can just fast forward it and you can see the other things. And I want to you to remember only one thing, that I can is 100 times more important than IQ. Thank you so much.